Now we'll move to our last talk of this session. Opportunities exist to further improve outcomes for patients with CML, presented again by Dr. Professor Breccia. The floor is yours.
So thank you again also for the second topic. So what opportunity exists to improve outcome, and we can review together some, I believe, new data and important data. So these are, again, my disclosure. I subdivided this presentation into different lines of therapy. The first line treatment you see already before the ask for first, so asciminib enter into our therapeutic algorithm because it was approved by FDA, and we are near to the approval by also EMA in Europe. You know that in this trial, patients were randomized 1-to-1 asciminib versus investigator selected TKI, so it means that we have two cohorts, asciminib versus imatinib and asciminib versus second generation TKIs. And the primary endpoint, the MMR at week 48 already achieved, was maintained at 96 weeks of follow-up in favor of asciminib versus imatinib, and also versus second generation TKI. So you see that the delta increased from 8.2% to 15%. A very manageable option because the most common side effects recorded were thrombocytopenia, hypertension, and increased lipase. So compared to the imatinib, reduce all the side effects of these drugs, such as, for example, fluid retention, edema, muscle cramps, or gastrointestinal side effects, versus second generation TKIs indeed reduced biochemical abnormalities also and off-target effects. So a sub-analysis of the first data of the ask for first showed a possible advantage for all the subgroup of patients, including patients identified with high U.S. long-term survival risk, very elderly, so patients aged 75 or more, and even with an increased Framingham score, so even patients that had previously cardiovascular comorbidities. And new data have been reported at the last EHA meeting regarding the quality of life study of the ask for first at week 48. So you see that patients stratified with the ORTC quality of life C30, more patients receiving asciminib had improvement in fatigue, pain, cognitive and functional and social functional aspects, even if we consider the specific ORTC CML24 questionnaire. So most of these common are improved with asciminib, only except satisfaction with social life. And when we use also some patient-reported outcomes specific to measure the tolerability, such as the FACT-GP5, it showed that the majority of patients that received a new drug were not bothered by treatment side effects, so suggesting a better tolerability in the long term. What about the mutations? A possible problem, we don't know. So we have 10 out of 200 patients who developed specific myristoylic site mutations, but only one patient progressed to blast phase inside this group, and most of these mutations were rescued by second generation TKIs or with ponatinib. The other novelty is the German ask for start, a phase 3b study indeed that randomized newly diagnosed patients to asciminib 80 mg QD again versus nolotinib, but with a completely different endpoint. So the time to treatment discontinuation due to side effects and death. In terms of efficacy, but with a median follow-up of less than 10 months, it seems an advantage for asciminib in terms of EMR and MMR. Was recently updated at the ASH CML in Estoril and will be updated at the next ASH meeting. Probably asciminib was very near in terms of MMR to nolotinib. But the primary endpoint has been indeed identified and reached because very few patients, 5%, with asciminib leave the trial for side effects and death as compared to 12% indeed with nolotinib. And the most frequent side effects recorded with this drug are thrombocytopenia, headache, and myalgia. Now, the first group that tested asciminib frontline was the Australian group. We have now a follow-up at 28 months. So single agent, but with a possible dose escalation in case of suboptimal responses and add-on with all the other available TKIs in case of failure. Here, a co-primary endpoint, the EMR at 3 months is 93%, so seems very higher and more higher than what observed with second-generation TKIs. And the MMR at 12 months is 79%. Again, only one case of sudden lymphoid blast crisis and manageable because the most common side effects again recorded were hypertension, increased amylase and lipase. That was completely reversible. So different strategies have been also proposed as a frontline treatment. You remember the German study with the Tiger trial, sonelokimab plus PEG interferon that failed to achieve the endpoint of an increased TFR. This is the experience of MD Anderson. So dasatinib, low dose, 50 milligram plus venetoclax. A strong rationale, I believe, because as you know that positive stem cells are very rich of BCL2. But compared to dasatinib, single agent low dose failed again to increase the rate of MR4.5. Probably for the very low dose venetoclax at the end, administered to these patients, so only 100 milligrams for 7 days. But I believe that further follow-up here is needed to evaluate the possible TFR rate. Second-line treatment, again, asciminib. The unique trial here is the ASK2 escalate, but probably FDA and EMA will approve this drug also in second line. So here, patients who failed for resistance or intolerant, mostly for resistant, and mostly after second-generation TKIs were treated with asciminib 80 mg QD in a phase 2 trial. This is the first interim analysis. So the final follow-up with 101 patients will be reported at the ASH meeting. So you see that at week 24, about 43% of the patients achieved MMR, and very few escalated the dose because of resistance. Tolerable even in second line because the more common side effects recorded were fatigue and hypertension. Indeed, completely different is another drug, olverembatinib, approved in China for the T315I mutated setting, and so in later lines. Here, the first data indeed of this drug that was based on the scaffold of ponatinib in second line in patients resistant or intolerant to only one drug without a T315I mutation. 71% of the patients treated in this trial failed the second-generation TKIs. The rate of MMR, you see, even the same, 41%, but it seems more toxic, I believe, especially in China's population, a peculiar skin hyperpigmentation in these patients, hyperuricemia, thrombocytopenia, and hypertension are the main side effects. Third-line treatment, the current choice is asciminib versus ponatinib. Asciminib after FDA and EMA approval with the results of the ASCEMBL that tested in third line this drug versus bosutinib, and the final follow-up showed an advantage for asciminib not only in MMR but also in deep molecular responses. And now we have also the information that even in later lines we can use this drug probably in the future at 80 mg QD after the results of this other phase 3b study that was called AS4OPT that will be updated at the next ASH meeting again. So here patients were randomized 40 mg BID, the classic dose suggested, versus 80 mg QD as a schedule, and no differences were reported for safety and efficacy. In this trial also very few patients, 30, so truly intolerant but already in MMR were enrolled and switched to asciminib with an increased deepness of molecular residual disease. You know that FDA approved, but not EMA, indeed, the possible option of increased doses of asciminib, 200 mg BID for T315I mutated setting. These are the final results of the dose expansion part of the phase 1 trial. Probably with this new data, EMA, so we can try again to EMA to approve also in Europe this drug in third line. See here, 48 patients heavily pretreated before. The rate of MMR is 53%, but you see that there's an advantage for ponatinib naive as compared to ponatinib pretreated patients. And this important information that I believe will change completely our strategy has been also reported all over the world in the managed access program, so in the compassionate use of this drug. So for ponatinib, we know now after the results, the final results of the OPTIC trial, that we can start with 45 milligram for each type of resistance, not only for T315, but also for other type of mutations or for patients resistant but without mutation. But soon after the patient achieved less than or equal to 1%, we have to reduce to 50 milligram. So with this strategy, it seems that we can maintain the efficacy while reducing indeed the rate of arterial occlusive event. In this trial, 14% as compared to 32% of the previous PACE trial. As you know, no head-to-head trial were performed, asciminib versus ponatinib. This is a unique information about a real-life propensity score proposed by the group of Dennis Kim. 270 patients were extracted, then compared. So it seems that the rate of molecular response are similar, but asciminib exhibit a high failure-free survival as compared to ponatinib, and major advantages for patients who started asciminib with a molecular residual disease less than 10%. Asciminib is not the unique STAMP inhibitor. Other two are still ongoing, the TERN-701 in the Cardinal trial, but we have no data until now, and indeed the Chinese TGRX678. These are the results of the phase 1 study, similar mechanism of action to asciminib. So as you see, heavily pretreated patients here, 28% the MMR. Again, more toxic in the Chinese population. Most of the patients experienced metabolic side effects such as hypertriglyceridemia, hypercholesterolemia, or hyperglycemia. And it seems also that it's not able to rescue patients after asciminib or ponatinib failure. As indeed olverembatinib, these are the results of the MD Anderson trial. Even in patients without T315I can rescue indeed ponatinib, previous failed ponatinib or pretreated patients, with 40% of them that achieved MMR, and also in asciminib pretreated 30% achieved MMR. So quite uncommon. The toxicity in the US population is completely different to that reported for the Chinese population. Here, the more common side effects were increased CPK, thrombocytopenia, and increased transaminases, but not the skin hyperpigmentation as indeed reported in the Chinese population. And finally, also very important, I believe, information for the myeloid blast phases that we treated only with chemotherapy. This is indeed a chemo-free approach reported in a small cohort, but I believe very interesting of MD Anderson, is a phase 2 with the triplet association of azacitidine, venetoclax, and ponatinib together. So the overall response rate is 50% with a median survival of 11 months. So probably the future of treatment of these patients, a possible and very good bridge to transplantation for part of these patients. So in summary, as you see, most information about the new drug asciminib, now recently approved, and NCCN guidelines updated, and also the European Leukemia Net as a preferred new drug, but unmet needs still remain in later lines. New drugs are on the horizon, but the current choice is asciminib or ponatinib in third line, without an head-to-head trial that I believe indeed is further warranted. Thank you very much for your kind attention.